Good evening, everybody, and thank you for joining us for this webinar. My name is Naomi Halligan. I'm an intellectual disability educator and service navigator at Seston. I'd like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and I pay respect to elders past, present and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. So just a note about housekeeping. Please be aware that this session is being recorded and it will be available on the CESPN YouTube channel within the next few days. At the end of the webinar, an evaluation survey will pop up on your screen, so please do complete this. This will allow us to issue you with your certificates of attendance. We'll email it to you as well. Tonight's event has been accredited for 1.5 hours of education activity. So we will submit your CPD activity hours with our ACGP on your behalf. If you'd like to ask any questions as we progress through the session, you can type these into the Q&A button as well. I'd just like to take one moment to introduce Project Grow for those of you who aren't aware. So Project Grow is facilitating this evening session, and our overarching aim is to address the health inequities of people with intellectual disability. So we work to build the capacity of primary care providers and develop the health literacy of people with intellectual disability as well. Our project is part of the PCEP programme, that stands for the Primary Care Enhancement Programme for people with intellectual disability. Could we have the next slide, please? So Project Grow has 3 broad areas of focus. Today is an example of our education focus. And the other work we do within this area of education includes delivering in-practice sessions for all GP practice staff. So this is really to support you in your work with people with intellectual disability. The in-practice sessions really aim to help you get the best outcomes for this patient group through annual health assessments and also making reasonable adjustments and utilising communication strategies. We also facilitate education sessions for those people who work in the disability sector as well. So it's all about promoting partnerships between people working in the disability and health sectors. In addition to education, we also have an advocacy focus to ensure that people with intellectual disability are not overlooked, and a service navigation focus as well. And as service navigators, the Grow team really does welcome your questions and queries. So please do go ahead and contact us if you have any questions about referral pathways or local specialist health services for your patients. And you can see our contact details there on the screen. And there's also a link to the website where you can find some resources to download. Okay, so we'll now view some more information about CESPN initiatives as I introduce the speakers. Our first speaker this evening is Associate Professor Koncz. So Rebecca Koncz is a neuropsychiatrist and the New South Wales Chair of Intellectual Disability Mental Health. She is based within the National Centre of Excellence in Intellectual Disability Health at the University of New South Wales, Sydney. And she has a clinical academic appointment with South East Sydney Local Health District Mental Health Service. Her research spans neuropsychiatric conditions, ageing and dementia, and she leads the design and delivery of intellectual disability mental health education content for a diverse range of professionals. Rebecca is committed to partnering with people with lived experience, government and peak bodies in health and disability sectors to improve the mental health of people with cognitive disabilities. Secondly, our speaker, Dr. Murphy. So Dr. Jessica Murphy is a general practitioner with a special interest in managing patients with intellectual disability. She completed her GP training at the University of Manchester in the UK before emigrating to Australia in 2018. Dr. Jess is passionate about improving the health outcomes for patients with intellectual disability. And alongside being a GP, Jess works for the Centre of Disability Studies in the Complex Care Service Clinic and also as a clinical advisor for CESPN's Project Grow. Jess has a keen interest in medical education as well, and she tutors at the University of Notre Dame. Okay, so I shall now hand over to Rebecca and Jess.
Thank you very much, Naomi. It's an absolute pleasure to be here. I'll start by sharing some slides. Now, let's see. Is that coming up correctly to you? Or can you see my notes? It's okay.
We can see your notes.
I can see your notes. Yeah.
How's that?
Yeah, that's good.
Perfect.
Better. Fantastic. So I'm going to start before handing over to Jess, and we'll do a bit of tag teaming throughout this session. But thank you very much for having us along. It's a pleasure to be here. I too would like to acknowledge traditional custodians of the lands of which we're all joining from tonight, and pay respects to elders past, present and emerging. And I also want to acknowledge the value of lived experience of those with mental illness and cognitive disability that really shapes and leads the work that we do. So I also should acknowledge the support that I receive from Southeastern Sydney, the Ministry, and also the Commonwealth. So you've all received the learning objectives or aware of them. And so the way in which we thought we would address these tonight would be firstly to provide a little bit of context based on the data that is available before turning towards a more clinical focus, thinking about practical aspects of assessment in relation to behaviours of concern and mental illness, and then moving on to some of the management principles with specific focus on psychotropics. If you have questions, please do feel free to put them in the Q&A. We will probably come to towards them at the end of the session. We'll leave plenty of time for discussion. Okay, so when we talk about people with intellectual disability, they're obviously a heterogeneous group. But what they do have in common, unfortunately, is significant health and mental health inequities. So if we look at the prevalence of mental health conditions to begin, this is based off New South Wales data linkage, a study that was published just last month by people in our group that demonstrates that 76%, so 3/4 of people with intellectual disability will experience mental illness. And that is twice the rate of the comparator cohort, people without intellectual disability. And when we dig down into the data, we see that actually there are significantly higher rates of mental illness across a breadth of conditions, from anxiety disorders to mood disorders, psychotic disorders, substance use, suicidality, and personality disorders. I don't have it on this slide, but severe mental illness, so things like schizophrenia and severe mood disorders, affects people with intellectual disability disproportionately as well, at rates of around 16%. And the other kind of cluster of conditions that I don't have on this slide, but that does present with increasing complexity as the population ages, the dementias and other age-related conditions that occur in people with intellectual disability at a much younger age. Alongside of this, I think it's just really important to point out the significantly higher rates of other neurodevelopmental conditions as well. So that includes autism, that affects about 1/3 of people with intellectual disability, as well as ADHD and other learning disorders at significantly higher rates. And I think that's particularly topical currently, and creates additional complexities when we're working with these populations and thinking about how to assess and manage their varied presentations. So I'm going to come back to neurodevelopmental comorbidities a bit later. So alongside of the high rates of mental illness and other or mental disorders, there are significantly higher rates of psychotropic prescribing in people with intellectual disability, and I think that will be of no surprise to anyone online tonight. Prevalence estimates do vary, but affect more than probably for at least half of the population with intellectual disability are using at least one psychotropic medication, which is very high. And it's not even across groups. Probably antipsychotics is the most commonly overprescribed, but also antidepressants, anxiolytics, hypnotics, and then stimulants. But related to that is psychotropic polypharmacy, so 2 or more psychotropic agents at any given time, and is prescribed in about 25% of people. And of course, unfortunately, is associated with a range of side effects, anything from cardiometabolic side effects to movement disorders, hormonal side effects, and so on. So we are painting a picture, unfortunately, of significant disadvantage related to mental illness and their treatment. Alongside of that, there is significantly high prevalence of physical health conditions in people with intellectual disability. So this is data from a systematic review that was published a few years back now, but that shows a range of co-occurring conditions across a range of systems. And again, no particularly surprises, with very high rates of epilepsy, sensory impairments, being overweight or obese, and other cardiovascular and respiratory conditions as well. The thing with these co-occurring conditions is that sadly, multimorbidity is the norm, affecting somewhere around 2/3 or more of adults with intellectual disability. And the thing to note about multimorbidity, so that's 2 or more chronic conditions, is that it's disproportionately affecting younger people with intellectual disability compared to the general population, and in turn is associated with premature frailty and mortality. So there's high prevalence of mental health conditions, higher prevalence of physical health conditions, but different patterns in service use. So the data that's available to us based on New South Wales data linkage demonstrates that people with intellectual disability have twice the rates of emergency department presentations and twice the length of stay for inpatient admissions, which obviously is impacting services and quite cost. There's an economic argument that we need to be addressing this morbidity as well. In primary care, we take results from the Bettering the Evaluation and Care of Health, the BEACH study, which for those, as you all know, shows that there's less time spent on preventative health needs in general practice. There's more time spent on administrative versus actual clinical needs, and significantly higher rates of psychotropic prescribing. So this particular study found 10 times the rate of prescribing for antipsychotics. So there is significant, I guess, differences in the way that people with intellectual disability are accessing care. And sadly, putting this all together, people with intellectual disability do face premature mortality. So this was published some years ago now, but again, based on linked data from an Australian population demonstrating that people with intellectual disability on average die 27 years younger than the general population, with slight differences for males and females, but that overall the median age at death is was 54 years of age. And unfortunately, a significant proportion of this premature mortality is actually preventable. And so people with intellectual disability are twice as likely to die from preventable conditions compared to the general population. And the top 5 causes include the things that you would expect, things like cardiovascular disease, respiratory disease, infections, and so on. So this really does paint a picture of complexity, which in primary care obviously presents particular challenges. And we are really working at this intersection between one's disability, their physical health, and their mental health needs. And more broadly, needing to be thinking about all of the social determinants of health, housing, education, family supports, and so on that are contributing to these poor mental health and health outcomes. So with this in mind, this is the context that we are working with. And so we need to then be asking, well, what is the relevance to mental illness and what's the relevance to behaviours of concern? So before I dive into behaviours of concern, I think it's important just to define explicitly what we're talking about. And the definition's quite old, but it stands to this day, that behaviours of concern are culturally abnormal behaviours of such an intensity, frequency, or duration that the physical safety of a person or others is likely to be placed in serious jeopardy, or that it will impact on their access to community and quality of life. So behaviours of concern can present in a range of ways, and I'm going to come to that next, but the relevance is that actually we know that a range of things could be contributing to one's presentations when they're presenting to you, whether that be their mental health, whether that be their physical health comorbidities, as well as those other interpersonal or environmental factors. What are the types of behaviours that I'm referring to and might be presenting to you in your practice? There are the range. This is not an exhaustive list, but things like recurrent self-injury, aggression, whether that be physical, verbal aggression, or property damage, inappropriate sexualized behaviour, repetitive or stereotype behaviour, social withdrawal, eating, feeding issues, wandering, sleep disturbance being quite common, as well as hyperactivity, be it in the setting of an ADHD or not. So these can each in and of themselves be extremely challenging to assess and manage. So I guess from here we want to be thinking about together for the rest of the evening, how do we approach the assessment and management of these behaviours? So with that, we'll move on to assessment considerations, and I'll hand over to Jess. Thanks, Jess.
Thanks for that, Rebecca. So what I thought I would start by talking about is how to sort of generally approach assessing behaviours of concern in a general practice setting. And why this is important is that in this patient population in particular, sorry, I think my click is on delay. Oh, here we go. Sorry, I'll go back. The reason this is important is that we know that in this patient cohort, diagnostic overshadowing is a particular problem that we experience, or that the patients experience. And diagnostic overshadowing is where a person's symptoms are mistakenly attributed to their underlying disability, and blamed purely as being behavioural, rather than looking to see whether there's an actual underlying cause for the behaviour of concern. And this is particularly an issue in our hospital setting, where patients are often blamed, their behaviours are blamed on their disability rather than looking for an identifiable, treatable underlying cause. And why does that matter? Well, diagnostic overshadowing often leads to missed diagnoses, particularly with underlying physical health issues. And oftentimes it leads to increased prescribing of psychotropic medication, which is why we're talking about it tonight. And what then happens is that patients are simply prescribed medications for the behaviours, but the behaviours themselves actually then don't resolve, and they continue to go on, and they then actually worsen over time. It can also result to the implication of unnecessary restrictive practices being put in place, and I will talk about what restrictive practices are in more detail later. And of course, there's then care implications and cost implications as those behaviours continue. And ultimately, there is a risk with death if we're missing an underlying diagnosis. So in relation to this, I just want to highlight a case study. I don't know why this is taking so long to move on. There we go. So I just want to talk about Michelle. So Michelle, in May 2009, Michelle, who was 28 at the time, was taken by ambulance to an emergency department of a Sydney hospital after suffering a seizure at home. She'd been seen earlier that day by her GP with ear pain and a headache, and she'd been prescribed antibiotics for that. Prior to this seizure, she'd never had seizures before. Now, Michelle had a mild intellectual disability, and she was normally able to communicate for herself. But by the time she presented to the emergency department, she was exhausted and in so much pain that she wasn't talking anymore. She was rocking, moaning, holding her ears, and she required several rounds of simple analgesia throughout the emergency department stay. Despite her mother advocating for her and telling staff that the behaviour wasn't her normal, they attributed the behaviour that night to her intellectual disability. The documented diagnosis in the notes was a tantrum secondary to pain and frustration. No differential diagnoses were reported, no pathology tests were ordered, and no radiography was ordered. Nor did they consider admitting or keeping her longer for observation. Despite her mother's protests, they were forcibly discharged in the early hours of the morning. Unfortunately, Michelle died within 7 hours of being discharged from hospital. According to the inquest, the findings were that she had an undiagnosed acute streptococcus pneumonia meningitis with left-sided otitis media as the antecedent cause. And according to the inquest report, and by the way, this is freely available online if you want to research this, one of the registered nurses that gave evidence at the inquest had actually asked the doctor why Michelle was being discharged rather than being kept in for observation. And they were told that Michelle had not had a convulsion, but that her issue was purely behavioural. So as you can see, this is a real thing that does actually happen, ongoing, and it does have dire consequences. And it's important to remember that behaviours do have an underlying meaning, and understanding that can literally mean the difference between life and death in some cases. So in my experience from working in the complex care service clinic and just as a general practitioner, I think these are some of the commonly missed physical health presentations that can underlie behaviours of concern. In particular, things like poorly managed pain, constipation, dental problems. We know that patients with intellectual disability generally have very poor dentition and poor access to dental services. Foreign bodies in the ears that can go overlooked. And then classically with women's health, that periods are often quite poorly managed, particularly pain with periods. So how do we approach this in our practice? I think this is kind of a good schema of how we can approach this. And I think the important thing is that initially we pay attention to see whether there are any underlying physical health conditions that are promoting the behaviours of concern. And once we've satisfied that there aren't, we need to also consider mental health conditions. And Rebecca will talk more about that in detail later on. It's also important to consider whether there's been any environmental changes. Has the patient's favourite carer suddenly gone on unexpected leave, and that's just caused disruption to them? One of my patients recently had worsened behaviours because their mobile phone broke and they couldn't watch their favourite music videos that would settle them, for example. Once we've exhausted all of those things, that's when we can sort of say, look, this is purely a behavioural situation, and it needs to therefore be managed in such way. Now, in reality, all of these things will probably be happening concurrently. It's not like you do one and then move on to the other. But I think breaking it down in that way just simplifies it a little bit in our minds. And as a GP, what can we do initially to start this process going? And there's quite a lot we can do before we start getting any specialists involved. So the first thing, and I'm not trying to teach, grannies how to suck eggs or whatever that saying is, but I think it's important for us to kind of go over these simple things that are easy to overlook when the pressure's on. So I think the first thing to do is to do a bit of a case file review and have an MDT discussion with, if possible, the patient. If not possible because they aren't able to verbally communicate in that way, then their carers or their family members, with other allied health professionals that may be involved, such as OTs or behaviour support practitioners. What are the behaviours that are happening? What does that look like? And how has that changed compared to their usual baseline? So do they always have certain behaviours, but they've escalated in frequency or intensity? Or are these a complete new set of behaviours? When did they start? What happened when that started? Were they sick did they have a cold or a flu? Did the carer go on leave? Were they suddenly moved accommodation? Has there been any new physical signs or symptoms? Have any carers noticed anything? Have there been any recent medication changes that could have caused this? And it's really important, especially if they're in a supported independent living accommodation setting, there will often be charts that you can review. So things like their bowel charts, their sleep charts, and any behaviour charts if they do have a behaviour support practitioner. Now, that can be a bit more challenging if they're in a family setting where those things aren't being recorded, but that doesn't mean that you can't then implement those charts to get further data collection to help you figure this out. Have there been evidence of mood changes? Has the patient suddenly started becoming more emotionally labile or suddenly crying or becoming more withdrawn? And again, like I already said, are there any environmental changes that have happened over time? Now, this is not a fast process. It may actually take several weeks to get to the bottom of this. It may take months in some cases. But don't let this dissuade you from working through systematically with this process, because that's how we're going to uncover the root cause of this and slowly get to the bottom of it. It's unfortunately with these patients, it's not like the general population where you can have one visit, put some investigations in place and then solve the problem. We've got to chip away at it bit by bit, and that can sometimes be a little bit frustrating and hard. But trust me, the effort that you put in will pay off ultimately when we can reduce medication burden and when we can satisfy and manage the behaviours. And it's really, really important that we try our best to examine the patients. Now, this can be really difficult when they've got behaviours of concern, particularly any sort of aggressive behaviours. And we need to think about our reasonable adjustments that we are making to our consultations. So it may be that we need to use some pre-medication to be able to examine them. So, for example, you may want to use a very low dose of a benzodiazepine like a lorazepam or a diazepam just to calm them enough that you can do some examination. It might be worth thinking about what setting you examine them in. So if the patient gets really agitated coming into the practice, is it necessary that we do a home visit as a one-off? Is it that we go and see them in the car park, in the car, and take our equipment to them? And it's really important that we involve allied health support as much as we can. If they do have behaviour support practitioners in place, then use them to do some desensitisation techniques to allow us to examine as best as we can. Sometimes, though, it may not be possible to examine them without sedation, and that's then where we'll call in help. Obviously, consider our investigations as we need to. When did they last have a blood test? Can we collect an MSU? Thinking about one of the real main problems we see over and over again in this population is constipation. Can we get an abdominal x-ray and see if they're fecally loaded and then respond appropriately to that? Can we organise a dental check if they've not had one for a few years to rule out pain? And sometimes, do we need to do a CT brain to ensure that there's no underlying space-occupying lesion as a cause? Ultimately, if we are struggling, of course, then we refer on. And at that point, that's when I would involve your specialist ID health teams. I think we've got some details of them later in the slides. And of course, involving a psychiatrist if you're not sure of how to assess further. I just want to include a slide about safety. I think we've got to be aware that sometimes safety is really important to be aware of, in the sense that sometimes patients' behaviours become so elevated that they are a safety risk to themselves, to their family members, and to staff. And as much as we're saying we need to be systematic at looking at underlying causes and diagnoses, sometimes you might need to implement medications whilst you're doing that to ensure the patient's safety. So you may need to prescribe psychotropics temporarily to try to keep people safe whilst you're doing all of that at the same time. And that's okay. And we'll talk a bit about restrictive practices later in terms of how that might look. I also think it's really important that staff and family have a bit of a safety plan and know how and when to escalate, when to call in an ambulance, when to potentially call the police, because it's really hard when you're on the front line. They're the ones day in, day out that are having to manage this, that are being attacked sometimes. It can be really challenging for them, and we need to kind of give them support as well and recognise the importance of carer fatigue. Really, really important that we document all of this as well for our medical legal safety, for medical legally for us, but also again for clarity with what to do. Always be aware of the possibility of abuse as well. Let's not forget that these patients are extremely vulnerable to being abused. Hopefully that we don't have to face that, but I think we have to be aware that abuse does happen and have our eyes and ears open to the potential that that could be an underlying cause of their behaviours. And then I've kind of put at the bottom, don't forget red flags. And the reason I've put that there is because I have a concern that I think because these patients are hard to examine and because it's hard to get an accurate history sometimes, I do think sometimes those subtle signs of cancer can really be overlooked. So really think about, when was the patient last weighed? Are they actually losing weight? Oftentimes if they're in an accommodation setting, they aren't being regularly weighed, and that can be overlooked. Are they having those subtle signs like night sweats? Has their appetite changed? Are they having fevers? Because these things are, I think, things that lay people aren't necessarily aware that they should be on the lookout for. And I think sometimes behaviours of concern could be secondary to a neoplastic process. And I think that's really easy to overlook and to miss. And I think we just need to be aware of that. So that rounds up my little section there. I'll hand back to Rebecca for the next one.
Hey, thank you, Jess. Thank you for that fantastic overview. And yeah, just to follow up on that last point, we know that preventative health screening isn't done as well in people with intellectual disabilities. So that's a really good point that you make about having the age-appropriate screening done for cancer as best possible. The other thing just to pick up on are your points around safety. So that is part of a broader psychiatric assessment or mental health assessment, which I don't focus on. So thank you for covering that. But just to say, yeah, we like to, obviously, we try to avoid people ending up with emergency services where possible. But at the end of the day, we do actually have to put safety first and empower families and support people to actually recognize that it is okay sometimes. That is the best option for people to be accessing emergency services. So I'll move on a bit about the specific mental health or psychiatric aspects. And I must say, I think it's very much, people often say, I don't feel particularly confident in doing a mental health assessment in someone with an intellectual disability. But actually, it very much just incorporates the same principles as doing a mental health assessment for anyone, but perhaps with some tweaks. And that's where I'll call it the mental health or psychiatric assessment plus, just a few considerations. So you have already alluded to, Jess, important principles that we think more about with this population, and that is preparation and making reasonable adjustments. And I think that it is very easy to defer to informants, so family members or disability support staff, to provide the history. But it is really worthwhile thinking about ways in which we can maintain the person at the center of their own health care, and sometimes small adjustments to communication or the environment, as you pointed out, can actually go a long way to improving rapport and the assessment and care process. So broadly speaking, as you've already mentioned too, Jess, that we are thinking very carefully about the timeline of events and needing to do things concurrently, often that kind of thinking broadly about the differentials and thinking about the mental health and physical health assessments concurrently. When it comes to the mental health assessments, though, I think there are a few things that it is helpful to think about in addition. So that is the cause of the intellectual disability, what the level of the intellectual disability is, one's cognition and adaptive function at baseline and what it is now, the role of neurodevelopmental comorbidities, and then of psychotropics. So I'll just kind of speak to each of these in turn to explain why I think they're important additional elements to a mental health assessment. So what is the cause of the intellectual disability and why am I interested in this? I think it's actually very helpful to ask the question or understand whether previous genetic or chromosomal testing has been done, because it might help us to anticipate commonly associated medical comorbidities and tune our radars to go seeking them more proactively. But it also might help to explain their behavioural phenotype. So what do I mean by behavioural phenotype? There are a couple of well-accepted definitions, but the first one being a characteristic pattern of motor, cognitive, linguistic, and social abnormalities that is more consistently associated with a particular disorder, or a heightened probability that people with a given syndrome will exhibit certain behavioural sequelae relative to those without the syndrome. And I think it's probably more helpful if I just provide some examples of behavioural phenotypes and some that you're probably very familiar with. So we know that someone with Down syndrome is very vulnerable to the early accumulation of cortical amyloid and the development of early onset Alzheimer's disease. So that's very well known, but there are a range of conditions with well-described behavioral phenotypes. So velocardiofacial syndrome, for example, associated with high rates of ADHD, affective disorders, and a schizophrenia-like illness that affects up to 30%. Williams syndrome, where they're known to be hypersociable, or Smith-Magenis syndrome, where severe sleep disturbance, aggression, and self-injury are hallmarks. So they are some examples. So understanding the cause of the intellectual disability may give us some insights into the related mental illness that might be associated with it. Secondly, thinking about the level of intellectual disability and how does it impact on the presentation. So if we're thinking about things on a spectrum, at the more mild end of intellectual disability, we are more familiar with the more classic or typical presentations. People perhaps might be able to verbalize their internal experiences. So someone might be able to tell us that they're feeling sad or they're feeling worried about things. As the level of intellectual impairment increases, as does the atypicality of the presentation. So perhaps in the more moderate range of intellectual disability, we start to observe what we call distorted symptoms. So, for example, instead of someone presenting perhaps with frank persecutory or paranoid delusions, they might be describing people as mean, a carer as mean. And that would be an example of a distorted symptom. Whereas at the more severe or profound end of intellectual disability, we are much more reliant on informants' reports and what's referred to behavioural equivalent of symptoms. And so this is where I think having reliable informants as part of the assessment is absolutely crucial. But I know how challenging that can be when we're all very time pressured and people come in with a range of supports. It's not uncommon in my clinic that people are supported by people who have just very recently met them or on that day started working with them. But so understanding the level of intellectual disability helps us to understand and tease apart those symptoms and what might be more reliable. For behavioural equivalents, sleep and appetite I find really useful markers that can also be documented by support staff and reviewed. So that's the level of intellectual disability. The third thing is really understanding someone at their baseline. Who is this person when they are well compared to how they are impacted by their presentation now? And the way I broadly think about this is in terms of their adaptive function. And my brain works by trying to simplify things. So looking at these three domains, I just think very broadly about I start with the practical domain. So when someone's well, are they able, what's their level of ability with their self-care, organising tasks, and so on. The conceptual domain, covering things like memory, the language skills, so that's both their expressive language and their receptive language, what they're able to understand, reading, writing, numbers, that kind of thing. And then the social skills being the third domain. And it is really important to try to tease apart who is this person when they're well compared to how they are presenting now. So that's thinking through the importance of adaptive function. The fourth thing I mentioned earlier about the very high prevalence of neurodevelopmental comorbidities. I'm predominantly talking about autism and ADHD. And it is worth screening for because it can significantly impact on someone's presentation. So, for example, if someone is autistic, how to interpret something like self-talk in the context of a question of psychosis. Is this self-talk as part of their autism spectrum disorder? Is it actually the hallmark of a new psychotic illness? So in order to do this, it does again require reliable developmental history, and that requires a reliable informant. So I do recognize the challenges with that, but it is something that I think can be easily overlooked. So that's why I've added to the list of things that we should be thinking about as we are assessing people. And then the final thing that I'll just flag that I pay particular attention to is that could the presentation be secondary to medication or medication changes? So I earlier had made reference to the very high rates of psychotropic prescribing, and that polypharmacy is a major issue. And so side effects are an important differential diagnosis. And this is because people may not recognize and verbalize their experience of side effects in the way that you or I could. Some examples of this I think about with the behavioral activation with the SSRI class of medication that can be quite common in people with intellectual disability. They may not be able to describe that they feel restless, but they will be observed to be pacing around, more agitated, not sleeping at night. And similarly, things like akathisia with the antipsychotic medications, it can be misinterpreted as increased agitation as part of some kind of mental disorder or illness, but in fact, is related to their antipsychotic medication. So I think it's actually really important that we have a high index of clinical suspicion that medications could be contributing to someone's presentation when they are presenting with behavior change. So they are some key thoughts that I have around the mental health assessment components. So let's now move to thinking about the management considerations. I'll kick this bit off and then I'll hand back over to Jess. So I think the management principles will really are not going to be of surprise and is what everyone is doing in their day-to-day practice anyway. But essentially, it is to identify all contributing or reversible factors and treating them, that we think about non-pharmacological strategies generally as first line, and then we'll think together about specific medication considerations, prescribing in people with intellectual disability. I should say something first on the non-pharmacological approaches. And I guess we are aware of the benefits of a multidisciplinary team, whatever the setting we're working in, but we may not always have access to that. And we are very, very commonly reliant on accessing this team through the NDIS. And I recognize this comes with its very own set of challenges, but where available, the types of things that I am advocating for are things like the involvement of a behaviour support practitioner. They are the ones who will be providing a comprehensive functional assessment of the behaviour. And I haven't talked a lot about that this evening, but apart from medical contributors or contributors attributable to mental illness, we do think about behavior as a form of communication. And so understanding what is triggering or associated with the onset of the behaviors, what mediates these behaviors, and then working on preventative and reactive strategies. That's a whole talk in and of itself, but that is what we're very reliant on behavior support practitioners for. We also often make recommendations for involvement of an occupational therapist, and they are helpful in many ways, particularly around sensory assessments. We know that there are a range of sensory differences and sensitivities in neurodiverse populations. And so to have a systematic review and recommendation of strategies around those sensitivities can be really helpful, and that's done by an OT. Other things like developing routine and structure. Boredom is a huge contributor for many in terms of behaviours of concern. OTs are really helpful working with that. Speech pathologists, many people I've worked with behaviours of concern have associated frustrations around communication. And so having a speech pathologist to optimize the communication supports can be really helpful. And often it can be a very difficult landscape to navigate for families. So I am often asking, is there an NDIS support coordinator involved? Can they be working with the family to understand, is the level of support adequate, and thinking about whether a plan review is needed and what evidence needs to be collected to really optimize things there. So I won't say too much more about non-pharmacological approaches, but in a nutshell, just to acknowledge that I think all of us are quite reliant in working across health and disability sectors in order to meet these needs. So, medication. I think I wanted to point out that it really is an evolving landscape that we are all working within. We know from the Disability Royal Commission that psychotropics are overprescribed. And the other issue that frequently comes up is that this boundary between treatment for mental illness and use of medication as a chemical restraint is very unclear. And many of us actually find that distinction impractical and quite challenging to work with. So in response to the Disability Royal Commission, a number of recommendations were made in terms of medication use in people with intellectual disability. So some ones to point out that the legal frameworks for the oversight of restricted practices need review. And actually that is a very active discussion in New South Wales at the moment. DCJ are currently reviewing the legislative framework for restrictive practices in New South Wales. So watch this space. We should know more about that in the coming months. But the other points around data collection and reporting on psychotropics and improving training are really with the view to reduce restrictive practices and reduce medication use in people with intellectual disability where appropriate. So that's one major contextual factor. The other one that is worth knowing about that was only published last year was this clinical care standard and psychotropic medicines in cognitive disability or impairment, which really sets out what is expected of clinicians in health and health services in prescribing for people with cognitive disability. So this is not specific to people with intellectual disability. It applies across other settings, such as working with people with dementia. But I think the principles are really foundational, and again will be of no surprise in terms of ensuring that medication choices are person-centered, appropriate consents in place. We're thinking about the assessment and then non-medication strategies first line, that we are having appropriate indications for prescribing, then the monitoring review and information sharing at transitions of care. So perhaps I'll speak to some aspects of this in practical terms. So when might psychotropic medication be helpful? So if there is diagnosed mental illness for which psychotropics are indicated, definitely psychotropic medication could be helpful. In the setting of behaviours of concern, we start to think about medications when behaviours are severe and non-responsive to non-medications strategies, and or there is risk associated with the behaviour, as Jess has already referred to. That we need to have thought about other reversible causes and treated them first, that the potential benefits are likely to outweigh harms, and that this is really part of developing a good co-designed treatment plan where appropriate consent is obtained. And with that, really good baseline data of the symptoms that we are trying to target, whether it is recurrent self-injury, whether it's sexualized behavior, whether it's aggression, because that is the only way that we can serially review the effect when there is good information available at baseline. Which medication then is a common question. I have to say that when prescribing for behaviours of concern, there is very limited evidence on which agents are most appropriate. So we know that in the setting of autism spectrum disorder, for example, there's Cochrane level evidence around risperidone and aripiprazole as two agents that may improve particular symptoms such as irritability, but that does come with a warning because of the side effects that are associated with these agents. So then we are needing to think in more practical terms. What are the choices to consider? This is based on a range of preferences of the person and supports. So I see some people who are very keen to trial a range of medications, others who are quite cautious about the use of medication. The administration and monitoring requirements of the drug. So something like lithium, where it may be gold standard in a bipolar affective illness, if someone doesn't tolerate regular blood tests, that becomes a difficult agent to prescribe. We think about medical comorbidities, past response to treatments, including adverse effects, and thinking about that potential for drug-drug interactions as well, and minimizing polypharmacy where possible. So what are some practical examples? Well, we can think about medication by disorder, and it's very much that the same principles apply. So if someone is presenting with a severe anxiety disorder or depressive disorder that haven't responded to psychological therapies, SSRIs are first line. The thing is, I would tend to start at a lower dose and titrate generally more cautiously than in the general population. And as I'd mentioned earlier, that we just need to be vigilant that a change in behaviour might actually represent an adverse effect, such as a manic switch, for example, if someone started on an SSRI. Similarly, for other conditions, I've mentioned bipolar disorder. Lithium is one that can be tricky because of the monitoring requirements. And for psychosis, again, implementation or commencing antipsychotics, I tend to start at a lower dose and titrate more cautiously, regardless of which agent we've selected. Clozapine is a particular medication used in treatment-resistant schizophrenia that does require initially weekly blood test monitoring and then monthly monitoring lifelong. So that is a medication that is not often tolerated by people who have difficulties with blood tests. So there's some examples by disorder. Then by comorbidity, because as we know, psychotropics are unfortunately associated with a range of adverse effects. Epilepsy, for example, very common in people with intellectual disability, but a number of our medications do lower the seizure threshold, so we should be cautious about that, such as the tricyclics and antipsychotics. We know that cardiovascular risk factors occur at higher rates in people with intellectual disability, and so unfortunately, medications like Seroquel or olanzapine will only add to that cardiometabolic burden. Respiratory or swallowing difficulties, avoiding more highly sedating medications or those that might increase the risk of aspiration or exacerbate swallowing difficulties. And in dementia, early onset in people with intellectual disability, I think that is an interesting one. I think we should, as with anyone, be avoiding that anticholinergic, and those with anticholinergic effects or sedative effects. Whether we should be using cognitive enhancing medications, though, things like donepezil, to slow that decline. I think the jury is still out for people with intellectual disability, and the challenge is often with tolerability. The side effects are problematic. So that's where we can think about the disorder or comorbidity. But just to say a few more words about pharmacological management of behaviours of concern, as I have already referenced, the evidence for the effectiveness and safety of these medications used in this context is really limited. So we are limiting medication use to those indications that I had mentioned when behaviour is quite frequent and severe in nature, that there is risk to the person or to others, and that other treatment options have not succeeded. Typically, these medications should only be offered in combination with psychological or other interventions, and if it is being used to treat behaviours of concern, that is considered chemical restraint, and Jess is going to talk more to that, but it does need to be part of a behaviour support plan. And those principles of starting low, titrating cautiously apply here as well. Apart from the slow and cautious initiation, I think monitoring for side effects, we do need to be particularly proactive about that because of that potential that they won't be volunteered to us as readily. We need to review the effectiveness within a reasonable time frame. And Jess mentioned the importance of documentation. I think that's it's particularly important when it comes to medications as well, in terms of the rationale that target behaviour and consent. And it does become very helpful down the track when we're trying to work out what medication has been trialed or used and why things have been stopped in the past. To have some documentation of that is so incredibly helpful, and that we're always aiming for the lowest effective dose. With monitoring, I think I work fairly closely with the person, families, and their or support workers to really talk about side effects, not to deter people, but just so that they understand and can be empowered to do something about them if they notice them. Because part of, I guess, although we need to review in terms of side effects, actually we're very reliant with people who are providing that care to be giving that feedback to us as well. And that sometimes discontinuing the treatment is actually a good option if the medication's ineffective after a period of time, if it's not tolerated or no longer required, and again, documenting the rationale. So just to that final point, just as much as we've talked about prescribing, I think it's actually really important to think about deprescribing. And it's been quite topical lately with the Maudsley's release of the deprescribing guidelines for antidepressants. With people with intellectual disability, similar principles do apply. I often inherit people's care on a truckload of psychotropic medications, not knowing really why they were commenced or if they are needed. But it is really important that I am thinking to myself, is the medication still indicated? Are there side effects actually now outweighing their potential benefits? When I'm deprescribing, I do it cautiously. I do it one medication at a time and slowly, very, very slowly. I again will engage patients and carers and talk about the potential for discontinuation effects. And because I think people often confuse signs of relapse with signs of discontinuation or withdrawal effects. So having to be clear about that distinction and developing a plan what to do about it. Providing written instructions. And as I'm winding back on medications, I will really only choose to do that when other aspects of a person's care is relatively stable. So if they're going through a lot of life changes or particular stressors, that is not a good time for me to be thinking about deprescribing. But as I am deprescribing, I am wanting to engage that multidisciplinary team as the behaviour strategies might need to ramp up, or the other sensory strategies might need to ramp up as I'm winding back on the medications. And of course, finally, you can always consider referring on if needed. Jess works at the wonderful complex care service led by Centre for Disability Studies, University of Sydney. Local mental health acute care teams are available. There are also 2 statewide intellectual disability mental health services and the specialist intellectual disability health teams, which for CESPN would reach into Sydney Local Health District and Southeastern Sydney LHD. So with that, I'll hand back to Jess on restricted practices.
Thanks, Rebecca. I think that was super helpful and super practical from like a GP level of how we can actually do this practically. I wanted to talk about restrictive practices just because it's a bit of a difficult entity to understand and wrap our heads around, and something that if we don't have a lot of patients with intellectual disability, we might not actually really know what that is. So essentially, restrictive practices are essentially an NDIS thing, really, in the sense that it's basically, in a nutshell, they define it as any practice or intervention that limits a person's human rights or freedom of movement. And as we've alluded to in the presentation, it's basically to keep people safe. And why, in terms of the further guidelines from the NDIS around restrictive practices, sorry, my screen is failing to move on again. Thanks, Rebecca. Oh, I've gone too far now. It's delaying. Anyway, in terms of their requirements, their restrictive practices have to be clearly identified in a behaviour support plan. There is an authorization process that exists in each state or territory, so it has to be authorized in accordance with that process. It has to be used as a last resort in response to the risk of the harm after we've explored other in this case, pharmaceutical proactive strategies. Has to be the least restrictive response possible, to aim to reduce the risk of harm and be in proportion to the potential negative consequences of that harm, and be used for the shortest duration possible. In addition, if the person can't provide their own valid consent, it's consent required from a guardian with specific authority for restrictive practices. And there's a specific, in New South Wales, there's a specific restrictive practices panel that exists for reviewing these. And if an accommodation provider starts to use a restrictive practices that hasn't been authorised, they have to report that to the NDIS Safeguarding Commission for review. And sometimes that has to be done in an emergency situation. So what are the types of restrictive practices? Seclusion, chemical restraint, which is what we're talking about, mechanical restraint, physical restraint, and environmental restraint. So that can be things like locking doors or locking access to fridges, for example. Now, why is this important to us as GPs? Well, we don't actually really do very much in this process. We don't have to sort of start talking to authorization panels and things. Usually it's the accommodation providers or the NDIS support coordinator that will be responsible for doing that documentation. However, we usually need to give evidence as to why we're prescribing something. And what we may be asked to fill in is something called a medication purpose form. I've put a little photo of it on the left there. And what this is basically saying, why are we using this? Is this being used to treat an underlying diagnosed condition, or is it being used as a chemical restraint? And the reason for this is that when people live in a residential care facility, like a supported independent living accommodation, a prescription doesn't provide enough authorization for a support worker to administer that if it's for chemical restraint. The service providers have to then receive authorization from the panels to say that they're allowed to give that. So this is why we're being asked to do these forms. Now, that's not to say that I agree with this burden of paperwork, but unfortunately, that's just this is what we're living in at the moment. And I suppose sometimes we may be asked to fill these forms in on behalf of specialists or other people that have initiated these medications. Now, as a GP, that's incredibly frustrating. I'm not sure that that's right. And I think we would well be within our rights medical legally to decline to do that if we've not been the initiator. And I think that's got to be on your own individual decision as to whether you're happy to fill those forms in or not. And I think you would be within your rights to say no if you're not the person who's prescribed it or initiated it, and to pass it back to a specialist. But I know from being on the support worker side of things, they get pushed back from specialists from filling it in, and they're kind of then caught in this no man's land situation. So I think, we don't want to be too obstructive, but equally we need to protect ourselves medically legally. And I think we just need to be aware that when we are prescribing, we are bound by rules and legislations that do exist in New South Wales around restrictive practice. So we just need to be aware that when we do a prescription, that's not where it stops. So what isn't a restrictive practice? Well, any medication that is prescribed to treat an underlying condition is not a restrictive practice. So for example, if we were using, Seroquel for schizophrenia, that's not a restrictive practice. But if we're using it purely for behaviours, then it is. Some further examples are around pills. So if we use a combined contraceptive pill for management of dysmenorrhea and menorrhagia, that's not a restrictive practice because it's a clear indication medically for use of that pill. However, if a patient has behaviours of concern when they're on their period and it's because of the period, and we just want to skip periods to control the behaviours, then that is a restrictive practice. Interestingly, according to the NDIS, pre-medication for appointments, such as diazepam, as we mentioned earlier, isn't actually a restrictive practice. It's to enable treatment of a diagnosed mental ill health, physical illness, or physical condition, which is very interesting, really, and I don't fully understand that. But I would encourage you to have a little read around this because it is quite a bit to wrap your head around, and I've had to kind of go back over this a couple of times to deepen my understanding. And these are some of the resources where you can find information about that. In particular, therapeutic guidelines do have a good resource on that as well. And then I'm aware of time, so I'm going to just whiz through this last bit really quickly, but I just wanted to touch on the importance of regular health and medication reviews that we provide as GPs. Why do I think this is important? I think I want to try to empower us as GPs to be taking control of the care of these patients as much as possible. As you know, GPs should be the central spoke of a wheel in anybody's care, whether that's no matter who that person is, whether they're an adult, whether they're a child, whether they've in a residential care facility, if they've got an intellectual disability, because we're best placed to kind of have that overall view of all of the different things that are going on with that care. The specialist should sit, in my opinion, sorry, Rebecca, should sit on the outside of this wheel and feed into it. And we should be kind of having that overall approach. And I think what I want to kind of empower you guys is that this care for people with intellectual disability, the medical problems are not always in of themselves particularly complex. They're complex because there's lots and lots of medical problems and there's lots of comorbidity, but the medical problems themselves are exactly the same problems as we face in any person, and the management and diagnosis is often exactly the same. So we all have the skills to do this type of care. It can seem really overwhelming, but from my point of view, the overwhelming part is the logistics rather than the actual medicine. So I think, give it a go, try your best and try and do as much as you can for these people. Why is regular reviews important? Well, because complex issues become less complex over time with continuity care and with repeated reviews. And we all know that Medicare is extremely restrictive in providing complex care because the billing is terrible and doesn't give us they're not appropriately billed for those long complex consults. So I think we can make use of available item numbers to help us along this way. So I would absolutely advocate that every single person with an intellectual disability has an annual health assessment done. I would then make use of the GP management plans. Obviously, they're changing from the 1st of July, and the reviews can now be done every 3 months. And the item number for the reviews has risen to match the original plan. So I would absolutely be doing a review every 3 months. And you can then do your medication review in line with that review so that we're regularly reviewing the medications. I personally, for my complex intellectual disability patients, do an additional monthly review because I feel that way I'm chunking it down and addressing things bit by bit. And over time, it does actually become much easier and you become more familiar with their case. Make use of home medication reviews as well, because the chemists spot things that we've overlooked really, really commonly. This is the CHAP tool. I'm sure you're all familiar with it, and that's what we use for our annual health assessments. And then finally, before we go on to questions, I just wanted to highlight as well the use of case conferences. Some of you probably will be aware, some of you may not, that we can bill for case conference time. And there's 2 separate item numbers. There's one where if we've organised and coordinated the case conference, or if we've just participated in. They're time-based, but you do have to have 3 health practitioners involved in the case conference. So it can be a GP, a specialist, and an allied health, or a GP and 2 allied health. I'm not sure that support workers fit into that, but it's on MBS online, so you can go and have a read about it if you're not familiar with it. So that's my bit wrapped up, and I think we'll have some time for questions.
Yeah, I'll just comment that I've included some resources on the slides that may be of help to people, including on our website, and some specific resources around prescribing. And with that, we'll say thanks.
A very sincere thank you to Dr. Jessica Murphy and Associate Professor Rebecca Koncz. Thank you for sharing that very important information. I can see from the questions that have come through that it's really sparked an interest. So we do have a few moments for questions now, and we'll start with Brendan's question, please.
Thank you for that. Now, look, what does shared care look like? What does really best practice shared care look like from a GP perspective interacting with specialists and the other healthcare teams? Because you've spoken about that before, Jess. So what does best practice shared care look like?
Yeah, so I think from my point of view, I think it's making sure that we are communicating openly with the people in that team. So making sure that when they've seen specialists that we're asking for timely feedback in the form of reports, and if we're unsure of anything that's written in that, to actually reach out for clarification either via phone or via email or whatever best method that is. With the allied health professionals, I think it's important to link them in. I think in particular, I look after 2 patients that have got complex behaviours of concern, and I've found it very helpful to liaise with their behaviour support practitioners and their OT to find out what strategies they're doing. They've also reached out to me to ask, with their sleep, are any of their medications that could be contributing from my point of view? And that way we're ensuring that all bases are being covered. It is hard, it's time intensive and labour intensive. I personally find it easier to communicate via email with the allied health practitioners because you can answer quite quickly. But equally, you could make use of that case conference time if you can line a time up. So I think it's just putting effort in, and it's hard when we don't get remunerated sometimes for that effort with Medicare, and it can put people off, but it's so rewarding. And it's something that we've all got capability to do as GPs. Yeah.
Thank you.
Okay, we'll just go to the other questions now, or did you have anything else, Brendan?
No, that's all. Thank you. Go to the questions in the chat.
Okay, we have a question here from a participant. I look after a large group of patients with schizophrenia, intellectual disability, and multiple other comorbidities on about 25 medications. How do I go about working out whether a patient's extrapyramidal symptoms or side effects are due to Parkinson's or the antipsychotics?
I might leave that to you, Rebecca.
That is such a good question. Yeah, and I wish I had an appropriately good response, but I want to firstly acknowledge that unfortunately this is not an uncommon scenario, that we do periodically see this, and it can be really difficult, particularly when you're inheriting people's care on a range of medications where the original indication is just unclear. I guess specifically around whether to the movement disorder symptoms, whether or not they're due to medications or idiopathic Parkinson's disease, it's a very difficult question. Part of it is looking at, I guess, what the particular medication are, because not all antipsychotics are made equally in their propensity to cause Parkinsonism and the other movement disorders. So if there is, if there are one or more agents that are high potency and very commonly associated with Parkinsonism, that might raise my index of clinical suspicion. I guess I'm also thinking about concurrent symptoms. So it's the non-motor symptoms of Parkinsonism, idiopathic Parkinson's disease, sorry, that I might be thinking about, whether or not there's a family history. And at the end of the day, it is sometimes just very difficult. But this is where the opportunity, is it possible to deprescribe? Is the medication still indicated? That is what I'm thinking about. And if so, someone has developed Parkinsonism and there is an antipsychotic that might be implicated, is it still required? Could we look at stopping it, or at least reducing the dose? So it is very difficult. I do acknowledge that. The other thing to say is that I work with, I'm very thankful to have excellent GPs to reach out to, and also neurology colleagues for these complex cases.
I was going to say the same. I think the good thing is that firstly, you've even considered that could be a medication side effect is the first thing. And I think just these are really complex scenarios that I would, as a GP, I would definitely be making use of specialists' input and opinion. So if they've not already had a recent psychiatric review, I would get them reviewed to help you decide, can you start deprescribing? If you're not confident to do that yourself, that is. And absolutely get a neurological opinion if they've not had one recently or ever. Because these are the things that are really overwhelming as GPs. And I think, again, probably needs that bit of an MDT kind of input too, really. Yeah. But the good thing is that you're even considering it and looking at it in the first place, because that's what we want to happen. Yeah.
Okay, we have a comment. Someone's just like to say they're happy that emergency departments have changed. And there's one more question we have time for. Can people with intellectual disability behave intentionally or unintentionally in a manipulative manner towards their carers, parents, or other people with intellectual disability? Is this a personality disorder, and how do we manage it?
Do you want me to start with that, Jess?
Yeah.
So again, another good question, because it's speaking to someone's intention behind their behaviour. I guess we don't think of things necessarily as manipulative, but we are thinking about what is this particular behaviour intending, and what is it communicating. And so yes, things can, behaviours can be goal-directed and they can be seeking particular outcomes. And this is part of the functional assessment of the behaviour. Is it does the behaviour take place so that an individual can avoid a particular situation that they don't like? Is it a behaviour whereby they can attain something that they are seeking, whether that's a preferred activity or item or food or whatnot? Is it a way of asserting control over a particular situation or individual? So yes, it can certainly be goal-directed. And to your other point, yeah, people with intellectual disability can experience personality dysfunction and disorders. So it's a very good point. And particularly we see that in those with mild intellectual disability or borderline intellectual functioning, a very similar range of personality disorders that we can see in the general population. So the management, I think, really does require that functional assessment of the behaviour, then to tailor the treatment plan. So that's probably involving a behaviour support practitioner. There are, evidence-based treatments around some personality disorders, like dialectical behaviour therapy for borderline personality disorders. Probably adaptations are required for care with people with intellectual disability, depending on their abilities to engage. So there's some of the thoughts that I have around responding to that question.
And I agree. I think in my experience, the behaviours, that's where the behaviour support practitioners are particularly useful, because as part of their assessment process, they will usually identify if there are any kind of intended outcomes to behaviours of what the patients are doing, and that's then how you can then manage that non-medication in a non-medication manner. I think the other thing I'd like to touch on is that people with intellectual disability are essentially human at the end of the day. And if they're in an accommodation setting, they may just not get on with other people, and that's okay. You know, we all don't like some people and don't like certain behaviors that other people exhibit, and that it can sometimes just be as simple as that they don't get on with someone in their accommodation. Usually they try to match appropriately when they're put into an accommodation setting. So if they share a house or a room, they try to match people as best as possible, but obviously there's limitations to that practically and financially and things. So sometimes it can just be a matter of an environmental annoyance in some cases, and that's normal human behavior as well. So yeah.
Okay, well, that does bring us to 8:30. So I'd like to say again a very big thank you to Jess and Rebecca, and also to everybody who's participated this evening. We do look forward to seeing you again online soon. Please have a look at the CESPN website for information about other upcoming events. And please also remember to fill in the evaluation form. You can either do that by scanning the QR code, which will pop up shortly, or have a look out for it in your inboxes.